I've been given the task of talking about recognition of wide QRS tachycardia on by ECG. So without wasting much time, I'll move on. So the scope of the topic is going to be definition. Of course, I'm not going to talk about the causes, how we differentiate, and some algorithms which are very essential in prompt and appropriate diagnosis so that we don't misdiagnose and treat the patients appropriately, because some of these patients can be really sick and valuable time may be lost if you don't diagnose precisely. ECG is quintessential in diagnosing VT and differentiating it from SVT. And that's what the basic ECG is going to help us guide definitive treatment as well. So by definition, a QRS duration greater than 120 millisecond with a heart rate greater than 100 per minute, if it is sustained or non-sustained, will qualify as a wide complex tachycardia. So this picture is given in all standard textbooks. So one of the three most important causes to the extreme right is the VT. When the source is down there in the ventricle, almost 2/3 of cases of broad complex tachycardia is going to be VT. When we were students, we were told that if there is a wide complex tachycardia, you diagnose and can't differentiate and treat as VT, you will not be penalized. But that's not true anymore. We need to diagnose it precisely, and we are able to diagnose nearly 95% times accurately by ECG, and another 10 or 20% will be by SVT with aberrancy, which can be any atrial tachyarrhythmia, which goes down with some kind of refractoriness on the bundle branches. It could be atrial tachycardia, flutter fibrillation, even AV nodal atrial tachycardia, or accessory pathway mediated tachycardia. You can have a broad complex tachycardia with a antidromic tachycardia along the pathway, down the pathway, up the node will also be a broad complex tachycardia. And any atrial arrhythmia with an accessory pathway, if it is conducting, can lead to a SVT with antidromic accessory pathway conduction, leading to a broad complex tachycardia. So wide QRS tachycardia can be regular or irregular. When it is regular, it is most often a ventricular tachycardia. As I said earlier, 2/3 of the cases. It could be SVT with aberrancy. It could be antidromic tachycardia down the accessory pathway. If it is irregular, all the time we need to suspect an atrial arrhythmia. It could be a atrial tachycardia, fibrillation, flutter with variable conduction. Patients can have bundle branch block aberrancies, or it could be accessory pathway conduction as well. So the causes, as I said earlier, 2/3 are going to be VT, and the second most common cause is going to be SVT with aberrancy. Virtually any SVT with the bundle branch block aberrancy, bundle branch block conduction can lead to a broad complex tachycardia. And also drugs given for SVT can also make the conduction down the pathways refractory, and you can have a broad complex tachycardia. You should also not forget hyperkalemia, which can cause the QRS to get prolonged. And pacemaker mediated rhythm, increasingly we see patients with device implantation with some kind of tachycardia. And if it is irregular, it could be AF, and we need to have that in mind. And patients with VT, if they are on antiarrhythmic drugs, there can be huge cycle length variability as well. The important features for differentiation, of course, I will try to restrict to ECG diagnosis. Pacemaker rhythm is less than 1% of broad complex tachycardia, so history and physical examination is going to be very useful. We have to look for the stimulus artifact all the time before the QRS complex. And all the time, if it's conventional RV apical pacing, it could be it will be a left bundle branch block with the left superior axis between 0 to -90 degrees. And of course, increasingly we're doing CRT pacing, so we'll have all kind of features of biventricular pacing, which is beyond the scope of this talk. A pre-exit tachycardia versus VT is very important to differentiate. How we differentiate a VT from pre-exited tachycardia is if you're looking for a VT, we're looking at negative QRS complexes in V4 to V6, which is seldom the case with a pre-exit tachycardia, because it's going to come from back to front. So all the time you'll have a positive QRS complex V4 to V6. And also you will not have QR complexes in the precordial leads in any pre-excited tachycardia, but all the time if there is a QR complex in a broad complex tachycardia, it is most often a VT, and this has got a very high specificity of close to 100%. So this is an example of a very fast, broad and irregular tachycardia. It's called the FBI tachycardia. If you see, the RR interval is varying. It's really bizarre, and patient will always be in a hemodynamic collapse. And this fast, broad and irregular is all the time and atrial fibrillation, antidromic conduction down the accessory pathway. You quickly cardiovert, you start looking for pre-excitation in lead 1 and also the precordial leads, the sudden transition of the, again, all this points towards the posteroseptal pathway. So we need to have that in mind. As I said earlier, I'll go back and show you will have predominantly negative QRS complexes in the precordial leads, V4 to V6, and a QR, if any Q wave is there in the precordial leads, we are looking at an accessory VT, unlike as shown in this case, a fast, broad, and irregular tachycardia, which is not due to VT, and it is due to accessory pathway mediated conduction. There are plenty of features for differentiation, and history and physical examination is going to be very important here. All those patients who have a past of heart disease with past MI, angina, or heart failure have a positive predictive value of nearly 95% for diagnosing VT. And patients with VT are generally older. And SVT and aberrancy will often have similar episodes, recurrent episodes in the past. And if you do a clinical examination, we can look for Cannon waves on the JVP, and auscultation will reveal a variable S1 intensity. So it's all going to be very useful. And importantly, when we connect these patients to the monitor, there'll be a change in systolic blood pressure, which is not related to respiration. And of course, all kind of vagal maneuvers and whatever physical maneuvers we do when we suspect, we also block the AV node with adenosine. All that will help us differentiate broad complex tachycardia VT from a SVT. So 10 points are important there, starting from the duration of the QRS, the axis, concordance, the transition of the RS pattern and the precordial leads, some morphological features like right or left bundle branch block or ambiguous pattern, presence of Q waves, as I said earlier, in the precordial leads point strongly towards VT during tachycardia in a broad complex tachycardia, AV dissociation is a synco none for VT, and baseline QRS prolongation, lead AVR, which is very essential for diagnosing the VT from SVT, and of course also the R wave peak time in lead 2, the Powers criteria, which I'll be coming to subsequently. So we use all these 10, you can interchange them and then do a rapid diagnosis. As a general rule, for a left bundle branch block morphology, broad complex tachycardia, more than 160 millisecond, and for a right bundle branch block morphology, more than 140 millisecond, favors a VT. The sensitivity is close to 70%, validated by Wellens et al., where nearly 70% of VT had a QRS duration more than 140 millisecond, and none of the SVTs with aberrancy had a QRS more than 140 milliseconds. But not to forget, if the patient is on antiarrhythmic drugs like amiodarone or other class 1A and C drugs even, can prolong the QRS duration. And those VTs in a structurally normal heart can have a QRS less than 140 milliseconds. So that's what happens classically when the VT is originating from the fascicles. So the duration of the QRS will also depend on whether the VT originates from the septum or from the parenchyma or the ventricle. So this is an example of a very narrow QRS, bizarre looking arrhythmia. We see a right bundle branch block morphology. We see a lot of S wave in V5, V6, not too broad tachycardia, but then you have some very narrow complex suggestive of a capture beat down there, and you see the indeterminate axis AVR being positive. This is classical in young individuals with structurally normal heart, classical of a fascicular VT. So the morphology criteria has to be applied to lead V1 and V6. And when we look at lead V1 and we are looking at a right bundle branch block morphology as shown in the example, if lead 1 is showing a tall monophasic R wave or so-called rabbit ears like this, something like a NOS, R more than the R prime, we are looking at a VT as the common cause. And if the R is less and S is big in the lead V6, RS ratio less than 1, again strongly point towards the VT. Vis-a-vis SVT with aberrancy, which will have a RSR pattern as shown here, and no Q waves in the lead V1. And R is always more than S in lead V6. So this is very important, V1 and V6 for morphology criteria. And we need to have that in mind. So shown here is the SVT with aberrancy, RSR prime in right bundle branch block morphology in lead V1. And in VT, you see a tall monophasic R wave or so-called rabbit ears, where the R wave is bigger than the R prime. So R and also any R wave which is more than 30 milliseconds with any QR in lead V1 like this is strongly pointing towards VT. So the specificity of this morphology criteria for right bundle branch block morphology in lead V1 is close to 90%. Same way for left bundle branch block morphology as shown here in V1, we are going to look at the initial inscription of the S wave, and if it is sort of notched like this as shown here, and about there's a notch or a slur in the downstroke of S wave in lead V1 with the initial inscription more than 30 millisecond, and from onset of R wave to the nadir of S wave, it is more than 70 millisecond. It strongly favors a VT compared to an SVT where you see the downstroke is going to be real sharp, the R wave is going to be narrower, and you're going to be less than 30 millisecond, and this downstroke is also going to be less than 70 millisecond. So lead V1 for LBBB type of broad QRS tachycardia, this notch in the downstroke as well as delay in inscription from the onset of R wave to the nadir of S wave more than 70 milliseconds strongly favors ventricular tachycardia. Compared to lead V6, where normally we will not have any Q wave in SVT, and you will have a tall monophasic R wave, hardly any S wave. And if you have in a VT, you can have a Q wave, a small r and a big S, that is R by S less than 1, which will strongly favor a ventricular tachycardia. So as I said earlier, if the tachycardia is broad, there are two examples shown here. If a tachycardia is originating from the interventricular septum, we are going to have a really narrower QRS. Vis-a-vis, when the tachycardia is originating from the free wall, you will have a broad QRS tachycardia. So VT originating far away from the interventricular septum will lead to a broader QRS, and VT originating from the septum, there will be a more simultaneous ventricular activation. The wavefront of activation spreads down the normal electrical conduction system of the heart, and thus you will have a narrow QRS. The next important feature is the frontal plane QRS axis, because we know the normal axis is down there in this this horizon between 0 to plus 90 degrees. So anything which is towards the right arm, that is minus 90 to plus 180, strongly favors the VTs. Also, if somebody has a baseline shift in QRS axis, something like minus 30 or minus 60, if there is a more than 40 degree change in axis from baseline, it strongly favors of a VT, but then that is a less specific criteria. As a general rule, if a patient has a right bundle branch block with left axis deviation or a left bundle branch block with right axis deviation, it strongly favors a VT. This axis in this zone is called the no man's zone or the indeterminate axis, and this is virtually impossible for any SVT to generate this axis, because the SVT starts from the top and goes down towards the apex of the heart. So to have an axis in this zone in an SVT is unthinkable, is probably not possible as well. So the indeterminate axis strongly favors the ventricular tachycardia, the so-called northwest axis, and it cannot be achieved with any combination of fascicular block or bundle branch block. And as I said, axis in sinus rhythm is more than 40 degrees different during wide complex tachycardia. This also favors strongly a VT. And as a general rule, a left bundle branch block with right axis deviation or a right bundle branch block with the left axis deviation strongly favors ventricular tachycardia as the cause for the broad complex tachycardia. So this zone has to be borne in mind, and the only lead which is oriented towards this zone is lead AVR. So normally the AVR, all of us are aware, has a predominantly negative P wave and negative QRS. The moment you start having a positive QRS in the lead AVR, it strongly favors, during tachycardia, it strongly favors a ventricular tachycardia as the cause. However, outflow tract tachycardias, as shown here, you will have lead 2-3 AVF having very tall monophasic R wave, and we see a rightward axis, something in the 90 to 180 degrees, and it's a left bundle branch block with the right axis deviation. As I said earlier, it strongly favors a VT here. The axis in lead AVR, you see, it's not predominantly upright. It is not in the indeterminate axis. So this has to be borne in mind. So there always will be some exceptions to the rule. When you have broad complex tachycardia going on, and suddenly we have narrow complex, again, coming in between the so-called fusion and capture, which I will be coming to subsequently, it strongly favors ventricular tachycardia. The next important point is concordance of the QRS in the precordial leads. Concordant pattern is uncommon in SVT. Exception is pre-excited tachycardia, but it's very sensitive for VT, more than 90% sensitivity. And a negative concordance, that is V1 to V6, all QS complexes, is another way of describing a northwest axis and suggests a VT classically occurs with anterior wall myocardial infarction. So concordant QRS is diagnostic of VT, uncommon in SVT with aberrancy. Positive concordance, that is V1 to V6 all positive, or a negative concordance V1 to V6 all negative, is strongly favors ventricular tachycardia. It's very specific, less sensitive, so we'll have to have in mind. To the left on this picture is a negative concordance. To the right is a positive concordance. And then we see in negative concordance, lead AVR is showing some features which I'll be coming to subsequently suggestive of a VT. And this also to the right has features which are suggestive of VT. So positive and negative concordance, particularly negative concordance, has more specificity for a VT. So also, just like precordial leads, if you have predominantly negative QRS complexes in the limb leads, it is strongly suggestive of VT, because also another way of describing an extreme axis or a right superior axis, and it's very specific for a ventricular tachycardia. Sometimes we may not have concordance. If the concordance is not there in QRS complexes in the precordial leads, next is to look for the RS complexes. As shown here, you may have R, a small r, and a big S. So R to S complexes, beginning of R wave to the nadir of S wave, if it is more than 100 millisecond, is strongly suggestive of a ventricular tachycardia. As shown here, lead V4 has been zoomed here. So starting from here till here, the sensitivity is 66 and specificity is 98. So there are very few specific criteria which have such a high specificity. One of them is going to be this RS criteria, precordial RS criteria for diagnosing a VT. Sometimes the bundle branch block is not too clear. It may not have a classical W or an M pattern to differentiate it from a LBBB and a RBBB kind of tachycardia. But this kind of a aberrancy is highly specific for VT. The specificity is 90 to 95%. So if you have ambiguity in lead V1, we are not able to differentiate during tachycardia, left bundle branch block morphology or right bundle branch morphology is very highly sensitive of a VT. Presence of Q waves during broad complex tachycardia suggests an old MI, and most often it is VT. It is not that patients with old MI cannot have SVTs. Most often they have a VT, particularly in the background of a severe left ventricular systolic dysfunction. In general, patients with post-MI VT maintain Q waves during wide complex tachycardia that are present during baseline in the same leads. So whichever leads are showing Q waves will continue to show Q waves during the broad complex tachycardia. The exceptions are always there to this rule. In dilated cardiomyopathy, there may be Q wave during VT that are not present at the time of baseline, because this is a non-ischemic cardiomyopathy. So you don't have those Q waves at baseline, but you can have a Q wave during tachycardia. Also, pre-exit tachycardia, this so-called back to front, posterior to anterior connection, can have Q waves in the inferior leads. So this is an example of a scar VT, and you can see Q waves in inferior as well as anteroseptal leads. There is S wave in V4, V6, and we can see lead AVR showing a axis which is extreme. So we are having a negative Q waves, 2, 3 AVF, negative QS complexes, precordial negative concordance, deep S in V4 to V6, AVR extreme axis. So in one quick glance, we can make out that this broad complex tachycardia, or rather not so broad complex tachycardia, is a scar VT. So AV dissociation is perhaps the most specific ECG finding for VT. No SVT is virtually possible to have AV dissociation. However, there are exceptions to the rule. But then there are some clues, clinical clues for AV dissociation in the form of Canon A waves on the JVP, variable intensity of S1 heart sound, and systolic blood pressure changes, which is not related to respiration. So very important when we go and examine these patients in the ICU, we look at the systolic blood pressure pattern. There is no change in respiration, and the systolic BP tends to show wide swings. AV dissociation, we'll also look for variation in QRS amplitude during the broad complex tachycardia. As I said earlier, look for narrow QRS complexes, the so-called fusion and capture during a broad complex tachycardia. And of course, we can use other imaging modalities. Example of a broad complex tachycardia with the arrows showing the P wave, and you can see a change in amplitude of the QRS complexes in various leads, and there is extreme axis as shown here, deep SV5 to V6. So AV dissociation is a sine qua non for diagnosing of VT during compared to SVT. It is by far the most useful criteria It is seen in nearly half of patients of VT and practically no SVTs. And the presence of AV dissociation should be strongly suspected when there is a variation in amplitude of QRS during a broad complex tachycardia. And 30% of VTs may have 1:1 retrograde V2A conduction, and faster VTs are less likely to have 1:1 conduction. So some examples are shown here from our clinical practice. We can see the arrows showing the P waves, the retrograde P waves. The ventricular rate is exactly nearly more than half the atrial rate. So the A to V ratio is less than 1. It's not 1:1. It is 0.58. More V than A strongly suggests a VT in this not so broad complex tachycardia. Another example shown here, we can see P waves. These arrows are showing the P waves, the retrograde P waves. So every second QRS complex is followed by a P wave. So it's a 2:1 V2A conduction, nearly seen in 15 to 20% of VTs. Down there is the step ladder diagram, which is taken from a textbook, just to show different types of manifestation of VT in clinical practice. There can be a variation in amplitude of QRS. As I had said earlier, during a broad complex tachycardia, you see this. Some of them are bigger, some of them are smaller. You should strongly suspect a VT because the scalar summation of P waves on top of the QRS, and you can have multiple wide complex tachycardia configuration, and the sensitivity is about 55%. So we need to have everything in mind when we look at these complexes. So when we have such kind of a broad complex tachycardia going on, and we have something narrower in between, it could be a capture or a fusion beat. So that has to be borne in mind, and the RR interval is generally regular, and we will have a capture beat which has got a normal contour and which is slightly premature, vis-a-vis a fusion which will be a fusion between the sinus rhythm and the broad complex tachycardia. So another example of a broad complex tachycardia going on, and we can see capture beats in between like this, to the beginning and the end of tracing, and a fusion beat which is intermediate between the sinus rhythm and the broad complex tachycardia beat. So fusion and capture, if it is there all the time, it is going to be a VT, even if the QRS is not too broad, as shown in this case. So there are some caveats when we use AV dissociation criteria. The sensitivity is perhaps at the best 50%, and during fast heart rates, there can be inadequate duration of recording, so we may not get the fusion and capture all the time. And as I said earlier, only 30% of patients with VT have 1:1 VA conduction. And also rarely you can have atrial fibrillation and a VT going on together, and then it's very hard to diagnose AV dissociation. However, if you are able to diagnose, the specificity is close to 100%. So there are very few criteria which have that very high specificity. Baseline QRS duration is also important. If the QRS is broad at baseline, becomes narrower during the tachycardia, it strongly favors a VT. QRS during VT is narrower than during baseline rhythm, as shown here. To the left of the picture is in sinus rhythm. We see such a intraventricular conduction delay, old anterior MI, and then during tachycardia, you see it's a narrower QRS. So this is a very, very specific sign of ventricular tachycardia as the cause for the VT as the cause for the tachycardia. So wide complex tachycardia with QRS narrower than during sinus rhythm strongly favors a VT. So AVR is by far the most neglected lead, but then during a broad complex tachycardia, it becomes the most important lead, because if you look carefully at that, we are going to get a diagnosis of VT almost all the time. If there is an initial R wave in AVR, and we have to look at if the initial R wave duration, the VI, is more than 40 millisecond, and if there is a notch in the descending limb of the AVR, it's called the VT, the terminal portion of the AVR, and this difference between VI and VT less than 1 is very highly sensitive and specific criteria, perhaps the most sensitive and specific criteria for diagnosing a VT. So during SVT with aberration, the initial septal activation and ventricular activation are directed away from AVR. So you may not have initial R wave. It will be all QS as shown here, right bundle branch block, left bundle branch block, both. And that has to be borne in mind. But then a more blown up picture, initial R wave and the RS and terminal R also having a notch. And then if you look at the initial from the terminal part of the R wave in AVR alone, it will be highly, that VI to VT ratio less than 1 strongly favors the VT. However, SVT will have a sharp initial inscription. Virtually, you don't have a big R wave at all. So, voltage in initial part of the QRS, 40 millisecond or more. Voltage in terminal portion, 40 millisecond or more. And if a VI by VT is more than 1, it indicates supraventricular origin. If it is less than 1, it is all the time, it's going to be a VT. So, this picture is perhaps not so clear, but then we see the initial VI here in lead AVR and the VT here 0.15 and 0.6 less than 1 strongly favors a VT. Vis-a-vis another example shown here, the VI VT is more than 1, where the initial is more, more compared to the final part of the QRS. So that strongly favors a SVT. So last criteria is going to be the Powers criteria, where the R wave peak time starting from the initial inscription to the it's called the intrinsicoid deflection on lead 2 alone. R wave peak time more than 50 millisecond in lead 2 is simple and highly sensitive, and the specificity and sensitivity is just like AVR for diagnosing a VT, and that discriminates VT from SVT nearly certainly in every broad QRS tachycardia. So this is an example of an SVT with aberrancy. We see such sharp inscriptions from the initial part of the S wave to the nadir, hardly less than 70 millisecond, no S wave, lead AVR also predominantly negative, and when we terminate the tachycardia, the axis will be similar to this. So in a quick glance, we can make out that perhaps you're dealing with an SVT with aberrancy. A lot of algorithms, lot of criteria are given. I will not go into this. They have incorporated all of them together, basically based on the QRS width, axis, and certain patterns. Left or right middle branch block has been employed by Wellens, and looking for AV dissociation and axis combination with right and left bundle branch blocks is taken in the Akhtar criteria. And Brugada has a very high sensitivity and specificity, where they have looked at only the precordial leads. If there is no RS complex, all the time it is VT. If there is an RS complex, but R2S is more than 100 millisecond, again a VT. If you can demonstrate AV dissociation, again a VT. And if you look at the morphology criteria and V1, V2, and lead V6 for right and left bundle branch, with reasonable accuracy, you can differentiate. So Brugada is a very good novel criteria, where if you have all these, we are looking at a VT all the time. There are other criteria, as I said earlier. There is the Griffith criteria also, which is going to look at only right bundle branch block or left bundle branch block pattern, and peak to nadir of S wave. That also differentiates VT from SVT, and we have to just look at the QRS duration, the initial inscription to the peak or the nadir of S wave less than 70 millisecond strongly favors an SVT. I think I'm overshooting time, so I'm just going to rush up and go to the last criteria, the AVR criteria, where AVR, if you look at carefully during broad complex tachycardia, if you have an initial R wave, all the time it is VT. If you have an R wave or a Q wave, again it's going to be a VT. If there is a notch on the descending limb of the R wave, again it's going to be VT. Then measure the VI to VT, that is the initial to the terminal transcription, the voltage less than 1, favors strongly VT. The sensitivity and specificity is very high, this so-called Verikes criteria. So a diagnostic algorithm approach will be stepwise, looking at specificity of close to 100%. Is look at AV dissociation, it is VT. Initial R in AVR, it's a VT. QRS morphology, unlike bundle branch block, and then use the morphology criteria for RBBB and LBBB in lead V1. VT is diagnosed. VI by VT less than 1 in lead AVR. Again, we are diagnosing VT. So that can be a very stepwise, easy, quick fire, approach to diagnosing a VT. So we can employ all these criteria. What's been described in textbook is perhaps the best algorithmic approach for diagnosing a broad complex tachycardia is applying the Brugada with the AVR and combining the old with versus new, the VI by VT, as also looking at the extreme axis, the Verikes criteria. We can diagnose VT with reasonable accuracy. Having said that, all the time when the patient comes to us with broad complex tachycardia, we need to make sure the patient is stable. If the patient is stable, how do we say? Patient should have a good consciousness level, should not have ongoing angina, should not be hypotensive, should not be failure. If yes, one of the four is obviously unstable. So reduced consciousness level, ongoing chest pain, systolic blood pressure less than 90, and heart failure is unstable. you quickly go and shop, we can diagnose later on. If he's stable, he gives you time, you can try some pharmacotherapy as we do in routine practice. Not to forget that electrophysiological study and radiofrequency ablation of these arrhythmias is very safe, just like coronary angiogram and PCI, near zero mortality, and we are able to also offer cure in more than 95% of patients. So to conclude, a 12-lead ECG is very essential that we have a 12-lead ECG during tachycardia as well as at basal state so that we can compare and diagnose. As I said earlier, we have a very good success rate for these arrhythmias with radiofrequency ablation, and all the time we employ 3D mapping system, which is now readily available for EC localization and ablation. Thank you very much for your patient hearing. I'll probably stop here and